there. So you are tuned in to World Bipolar Day Conference 2025. Thanks to Bipolar UK. Thank you for all your donations so far. Thank you for tuning in far and wide. Thank you to my fantastic speakers so far. We've heard from Swagata Sen, who was talking about stigma in healthcare, and we were talking to Dorothy Herson, who was talking about stigma in relationships. So thank you, ladies, for that. Now, there has been an inundation, if that is a word, of questions to Bipolar UK about bipolar and the keto diet. And I wasn't aware of this. I said to the team, well, what's all this about? Why is everyone talking about this now? So we put together a panel of experts to answer as many of your questions as possible, and they're going to cover them in 30 to 35 minutes. Now, we've got Dr. Talen Wright, who is Bipolar UK's postdoctoral research manager. She works alongside the charity's director of research, Dr. Tanya Gergel, who's another lovely lady. And together they manage all the charity's research activities, and they do a fantastic job there. And then you've got Dr. Iain Campbell, is Bazuki Research Fellow in Metabolic, I always struggled to say that for some reason, Psychiatry at the University of Edinburgh. He lives with type 2 bipolar, which informs his work from a lived experience, which is great. And then you've got Dr. Samir, another friend of the charity, is a consultant psychiatrist, a clinical academic, and lecturer at King's College London. Samir mainly looks after young people with first episode psychosis, including bipolar. So over to you guys. I am sat here and I'm going to take notes.
Thank you so much, Leah. That was an amazing introduction. So hello, and thank you for joining us for this exciting conversation on metabolic psychiatry and the keto diet. So I want to say firstly a huge thank you to Samir and to Iain for joining us and taking the time to join me this evening. Before we get started, though, I got to do some shameless self-promotion on behalf of the research division of Bipolar UK. So I wanted to say that we are ramping up on several projects into a wide range of topics, including neuroscience and genomics, to name but a few. And with the help of our research community, we've been able to provide excellent advice to many of the projects we are engaged with. If you're interested in learning more about the research we are involved with, join our research community for updates and direct invitations to participate in all of our fabulous studies. Furthermore, we invite you to carry on the conversation. So we were inundated, and that is a difficult word to say, Leah, I completely agree, with questions. So sadly, we can't include them all in this session, but Iain's colleague, Professor Daniel Smith, will be answering your questions about the keto diet and bipolar on the e-community during a live Q&A on Tuesday, the 22nd of April from 1 to 2 p.m. Okay, so we know that many of our community want to try the keto diet, and as a charity, our official party line, as it were, is that there isn't enough evidence for us to recommend the keto diet for people with bipolar. But if anyone is thinking of trying it, it's vital that you manage the potential risks by speaking to a doctor before starting the diet, monitoring hydration and electrolyte intake carefully, and having regular blood tests to track medication levels and overall health. So I just wanted to get that out of the way before we now get into the questions. So hello, Samir. Hello, Iain. Hope you're both okay. Our first question is, what is the keto diet and how can it help people with bipolar? Who wants to go first?
I'll let Iain go. Is that all right, Iain? It's your forte, because I guess people understand the context of you being involved with this.
Yes, thank you for the invitation to be here. So the keto diet is a diet that causes the body to go into a state called ketosis, and most of the food that we eat is broken down into glucose, and this fuels the body and the brain. But in ketosis, energy molecules called ketones become the main energy source for the body and the brain, and this is something that occurs naturally when you're losing weight and burning body fat. But you can actually maintain ketosis in the long term whilst keeping your body weight by doing a ketogenic diet. And so ketosis is not a kind of new medication or a fad diet, but it's really a biological state that's natural to the body, that's existed throughout our evolutionary history. but it became a treatment for epilepsy in the 1920s when they observed that some people stopped having seizures when they were in ketosis. And there's now 100 years of use of this as a treatment for epilepsy, and it's had 13 randomized controlled trials. In bipolar, we're at the very early stages of research, and so this is why we can't recommend this as a treatment at this stage. This is just a new area of research that we're exploring, but it's interesting to note that bipolar shares medications with epilepsy. And so it's interesting to see that in a condition where we've had many medications come through from epilepsy, this other treatment for epilepsy, ketosis, may be useful. We're at the early pilot stages and we need to do a lot more research to understand this.
So I think, sorry,
Yes,
after you, Talen.
No,
No,
please.
not at all.
I was going to ask you actually what you think now. What's your take?
Well, I can't disagree with the factual component of it. So my background is I'm a medical doctor and a psychiatrist and psychopharmacologist. So I guess dealing with medicines and the treatment and care of people with bipolar. Iain's given a great description with a bit of history there, which I love, with a Scottish accent as well, in regard to the history of it. And again, it is what it is. It's a state where your brain is basically metabolizing fats as opposed to normally carbohydrate and protein. Was that the main question, was what is the keto diet?
So yes, what is the keto diet, which I think you've explained really well, and how can it help people with bipolar? So what is the sort of link here
Gotcha.
with bipolar symptoms?
Is it okay for me to talk about the evidence then? Is that all right with you, Iain?
Of course, please.
And as I read it, because I don't have any ties to it, which is great. So I'm not doing the trials in it. I've got no conflict of interest. I just want people to get better. And so when we're doing anything in medicine, you first need to have a concept for why it's being done, some sort of reasoning for it being done. And then usually in trials, you have a pilot trial. And what do we mean by that? You'll offer the treatment to a proportion of people and just see how it is in terms of safety profile and how it goes. So you wouldn't compare it to, say, a placebo or have any great degree of rigor. You'd first want to see, is there a so-called signal? Does it show any adverse events, any safety effects? And then could we do bigger and better trials? And the group that Iain works with, and you're first author on the publication, pilot study in Scotland, I think, was it 27 people, Iain?
Yes, and 20 completely.
Yeah, which so basically got offered a ketogenic diet, no great adverse events. It's on the web for people to read. But the important thing is this was a trial that was done in people, and it's led to a randomized controlled trials taking place. So people will now take part in further trials, more rigorous trials, just like in the rest of medicine. So there's a biological basis for it. There's a thinking behind the ketogenic diet. And as Iain says, it's in the early phases of trials, and it needs to be subjected to the same degree of rigor as anything else in medicine. We ask that for everything with mental illness, don't we? We ask that people get treated with a parity and the same way as you would in the rest of medicine. And that's what I think as a field, the ketogenic diet is what's going to happen with it.
I liked how you said, I just want people to get better. As a patient and a researcher, I have the same perspective. I really, my primary reason for going to research is to see people have better treatment and better health. And, I've lost family members to mental illness and suffered from it myself. And so we really have had very few new treatments in the last 50 years. And whereas many other conditions, like in metabolic medicine, have had many new treatments and many much more effective treatments, there's been relatively few in psychiatry compared. And I meet many patients in support groups with treatment resistance and severe metabolic side effects of current medications and really struggling with their weight. And so this is something that from a patient and researcher perspective, I definitely share the perspective of I really want to see people have better treatments in time, and we need to this is a good thriving area of bipolar research, and we can't say at the moment whether this will turn out to be an effective treatment for bipolar, but to support the research, I think at this stage is a great thing for the community to move this forward.
Yeah, I completely agree with all those points that you've raised. And, in science, we do want to push for new advances or new discoveries and new treatments. So I think that's excellent. I suppose something else that you mentioned there was metabolics. and metabolic psychiatry. And I think that not many people, myself included, really, to be honest, know what metabolic psychiatry is. So can you give us a sort of quick crash course on what is metabolic psychiatry?
Yes, so metabolic psychiatry is the study of metabolic mechanisms that might influence mental health symptoms and also the kind of physical metabolic aspects of living with bipolar. Many people struggling with obesity and dysregulated glucose. And so metabolic psychiatry aims to look at, is bipolar something like an energy condition in the brain, a dysregulation of energy? Many people, when they experience mania, experience heightened energy, and this goes back to the earliest clinical observations of psychiatrists like Emil Kraepelin almost 100 years ago, mentioning that his patients would be up through the night, kind of unable to stop working. They would be very energetic, and then when they're depressed, your body is just completely deprived of energy in a way that's hard for anyone to imagine. You really are stuck in a kind of stasis, and I've experienced that for up to 1 or 2 months, where you really almost can't leave your room or your bed because of the energy deprivation. So I think the sort of aspect of energy is very interesting, and the specific way we're studying this is called metabolism, which is how the body turns food into energy. And so if you can change something about the way your body turns food into energy, maybe that can help with some of this energy deprivation that's part of depression, and this heightened energy that's part of mania.
An amazing response.
And
Yes, Sabir.
no, I agree. We're just at the beginning of these things, which is great from a science point of view. But you've articulated it very clearly there, Iain. I would say it's going to metabolism. You've split it into two things, which I like in terms of energy in the brain, and our brain takes up so much of the energy from our body, so it will have effects, whether that's primary, so whether it's the main thing driving things, or secondary to other systems and how they work, we don't know, and we need to investigate that side of things. I think you gave a really nice description there of really what's happening with the dopamine system, isn't it? When someone has that lack of energy, drive, motivation, and you're slowed up. And there are so many questions to be asked, because you've got elevation of the dopamine system when we have mania as opposed to depression, and figuring out how that works with the energy in your brain and how your brain's metabolizing it and how it has an effect on things like memory. It's all very, very relevant stuff. And I think the most pertinent thing is what you're saying there about side effects, with the metabolic side effects of some of the medicines that people take, because that's what people tell us, isn't it? And it's mitigating that. So it's two separate, as I understand it, it's two separate concepts. There's the concept of what is innate to what we develop if we develop a mood disorder, elevated mood or low mood, and then the effects of that on our general physical health. And I guess it's the concept that the mind and the body are the same thing, and it's the same circuit for people. So yeah, it's nice. It's nice to see that people are thinking about that side of the science.
I've just picked up on your Scottish accent as well. It's hard to hear over Zoom, but good to hear another Scot on the call.
Thank you.
Yeah, I think there's really interesting research into what you said about dopamine and energy. Mary Ann Phillips was presenting
Mary
at
Phillips in
Mary
Pittsburgh.
Phillips.
Yes.
Yes. She was
Yeah.
presenting at ISBD this year about exactly that, the links between energy and dopamine, and maybe these high energy dopamine states are kind of enhanced energy, and this is related to dopamine function is really interesting. And there's certainly, I mean, the idea of metabolic psychiatry is kind of a new field, but there's many decades of brain imaging research and metabolic research showing that glucose is dysregulated in the brain in bipolar. And it looks like there might be something like a kind of heightened glucose metabolism in states of mania and lowered in depression, and this is related to dopamine and reward signaling. So I think even though this is a kind of new field, there's many decades of research showing this energy dysregulation, metabolic dysregulation in the brain and the body in bipolar that kind of give a basis for exploring treatments like this.
I think it is, and it's not for me to tell the community what to think, but it is nice. I would think that people feel that people are putting the time and energy and money into doing the necessary research into this, because we looked at the dopamine system in mania, and you do find an increased signal. There's so many questions there, and what's the point of the research? I think it focuses energy and thinking, and I think that's a huge thing for people, and also for people to feel validated in what they have, and that people are really pushing pushing proper neuroscience to understand things, just like it should be, you know, like it is with cancer and cardiovascular disease. Sorry, Talen, there'll be lots of other questions, so tell me to shut up when I need to.
No, not absolutely. No, I love the conversation that's happening. It's something that I kind of picked up on was how, you know, this sort of metabolic psychiatry with the energy states and glucose and dopamine and how it's all just sort of like a piece of the puzzle and it's all fitting together quite nicely. And that's what we kind of aim to do in research, right? We try to find these small pieces that can interlock into a bigger, more complex answer. It's never so simple as just one thing, is it?
It can't be. Evolution's too Mother Nature's too complicated.
Yeah. We love her though, don't we? So the next question is, what are the risks associated with the keto diet? I heard you talk about side effects just a brief little bit. So for example, there have been some references from the community pointing towards relapse of bipolar, particularly in depressive episodes, and concerns over the physical health impacts of ketosis and keto diet. What do we know about that?
So there's a lot of research on ketogenic diet from the epilepsy literature, and that's examined some of these kind of potential risks of a ketogenic diet. One of the ones that people bring up often is that it might increase cholesterol, particularly LDL cholesterol. And so this is a really important topic because it's related to cardiovascular health. And so there has been quite a lot of research on this. There was a study in BMC Medicine which examined 68 RCTs of a ketogenic diet on health outcomes. And basically they found that in general, ketogenic diet, like we saw in our pilot study, improves most cardiometabolic measures like body weight, reduced triglycerides, reduced glucose, insulin resistance, and so forth. But they did find that it increased LDL cholesterol. And this is quite a common finding that many cardiometabolic parameters will improve, but LDL will increase. And so there was kind of a study of this in the Journal of Clinical Nutrition that looked at 41 RCTs, looking at what happens with LDL. And it basically, this increase in LDL happens in a subset of patients, it appears. People with high BMI or moderate BMI tend to have either no change or a decrease, but people with low BMI can experience LDL increases. And this is a topic of debate, whether this is considered to be, you know, if you have improvement in psychiatric symptoms and your physical health generally improves, is LDL by itself a marker to be, you know, worried about? And it's a relevant debate, and there's an ongoing scientific research in this area. So that's one thing that has been considered to be a risk of ketogenic diet is an increase in LDL. In our pilot study, we didn't see a significant change in LDL. And in the Stanford pilot study that was published last year, they actually saw an increase in LDL as well. There was also an inpatient study of about in France that happened, and they saw a reduction in LDL. So I think it's something to be considered.
So that, I guess that's the physical health side of things. And it's a question in terms of longer term, isn't it? Because you'd be thinking longer term increased LDL cholesterol, is that something we can mitigate, like with other medicines? You know, and I think that's where the cardiology folk will come in, because this isn't in isolation just for bipolar. It's for people taking the ketogenic diet throughout. And that's the longer term as well. It's good that people are thinking about these aspects of things. And obviously with your physical health, you'll need all of these things monitored at the beginning. So cardiovascular, blood pressure, weight, obviously, and cholesterol, kidney function, electrolytes, just your basic things when you go and see a doctor. Now, what can happen with the diet, any diet and anything else? You can have an effect on your electrolytes. So that's something that you would want monitoring with your doctor. And in terms of the physical symptoms, pulse, blood pressure, these are things that people do, and people with bipolar are much smarter than the rest of us. So, you know, they're usually, in my experience, monitoring all of these things fastidiously. So the physical side of things needs monitoring, like with any treatment, like with anything. You would just give it the right time and care. Now, with psychiatric symptoms, as I read the literature, there's not huge signals for things happening. But if we think about all our treatments, and we think you talked about Mother Nature and homeostasis, if something makes things better, it can make them worse as well. That's a sign of an effect. If something has an effect, it could well have a side effect in a small proportion of people. and that just needs the adequate monitoring. And we've known that for treatments for like ECT for bad depression and bipolar, that some people can switch to mania. And so with any treatment that we have, just need to be alert to things, have a plan and monitor things. And I think if it wasn't to have an effect, it couldn't have a side effect, to my mind. So I think there is going to be a risk, but albeit in a very small proportion of people. But it's just being aware of that side of things. And that's the nature of medicines and what we do, in all honesty.
Yeah, I mean, this is a common issue, I think, with people, right? Is managing side effects and understanding sort of what side effects they may experience, or whether they should be concerned about side effects. And of course, you know, it's down to an individual whether or not something is manageable or okay. But just because there are side effects doesn't mean that we shouldn't be doing these sorts of interventions or treatments, right? It's just about understanding them and then, as you said, mitigating them. So, you know, we don't kind of come up with an intervention or a treatment and then say, that's it, we're done now, we can wash our hands of this, everything's fine. It's like, you know, you want to kind of make sure it works for everybody as far as possible. It's kind of nature of science, I suppose. It's always just something else, a little bit at a time, but we get there in the end. Did you have anything else to add, Iain?
Yes, just so I mean, I could summarize, if you like, some of the research that's happened that kind of examines this over the past few years. I mean, there's basically been two pilot studies. There's a Stanford pilot study that came out in 2022, and then there's our Edinburgh pilot study, and there was an inpatient study in a hospital in France. And there's quite a number of case studies in the literature and patient reports as well. But basically, the Stanford pilot study found that most of their participants, about 79%, had some level of psychiatric improvement, and they reversed their metabolic syndrome if this was present. And they tended to lose about 10% of body weight on average. They didn't have any adverse events noted in the study, physically or mentally, from the study. In the Edinburgh pilot study, we saw reductions in weight and blood pressure, and we saw a correlation between ketone levels and indications of improved mood and energy and reduced impulsivity and anxiety measured daily. But we did have one patient who was on a diabetes medication that lowers blood sugar, and he had a bad reaction to ketogenic diet. This is published in our 2020 primary outcomes. And so you do have to be very careful with diabetes medications if you do anything that affects your blood sugar. So that's something to be aware of as a risk.
Yeah.
And the inpatient study in France, all participants had a level of psychiatric improvement. 43% in this publication achieved clinical remission of symptoms, and there was no adverse events detected. So it seems like you do have to be very careful with diabetes medications, anything that affects blood sugar. And we'll find out more as we do RCTs about potential mental health, good and bad outcomes. So we hope to do a large 300-person RCT this year, beginning this year. And then we'll kind of really learn much more about these types of effects, positive, potentially negative, of the diet.
And to be clear, the diabetes medicine, so the GLP-1 drugs, so Mounjaro and Ozempic, you know, you'd really shouldn't be starting a ketogenic diet if you're taking those medicines, to be honest, unless you have millions of pounds to spend in a private hospital with your own physician every morning and evening.
Fair point. So yeah, I mean, with what you said about the research, actually, we're moving on to that now, because some people have been writing in and they've said that they're keen to try the keto diet in the hope of gradually reducing or coming off meds entirely. Having gained over 15 kilograms in this one person's case in less than a year. And they're asking if there are any research projects or trials that they can take part in.
Yes, so we aim to do a large 300-person RCT through the Hub for Metabolic Psychiatry. So this is a research hub funded by MRC, who are the Medical Research Council, and we'd like to do a large 300-person RCT. So you could certainly email me if you're interested to be a participant in this. I'm at iain.campbell@ed.ac.uk. You can find my email address online, and maybe I could send that to you to distribute. But this is really the best way to support this research. It's at the early stages, and we need to do large RCTs to really understand this treatment. So if you want to contribute, one of the best ways would be to sign up for research trials. There's many happening now across the UK, across America. There's about 20 registered clinical trials of a ketogenic diet for psychiatric conditions. So there's plenty of opportunities to be involved in research if you want to explore this safely with support from a psychiatrist and a doctor.
Mia, do you know of any other studies that are ongoing at the moment within keto?
Sorry, were you asking Iain?
Oh, I was asking you, Samir.
Oh dear, no,
No, just
I'm not
checking.
aware of any, and I think it's a good point for people taking part in RCTs and randomized controlled trials, because usually, and this is the way we were taught, is if you take part in a study, you should actually be getting better care than otherwise. That's the whole point of these things happening. And if you're not, just tell the PI, and I'll put them in the naughty corner.
Very true. Yeah, I mean, the Hub for Metabolic Psychiatry, we know of it well at Bipolar UK, because we are also working with another hub within the MRC, the Brain and Genomics Hub based at Cardiff, with some people also in Swansea and Exeter and Bath, I believe. So it's a really good opportunity, and the MRC is very keen on getting sort of a wide range of experiences and really diversifying their inclusion. So if you feel like you are up for it, definitely get in touch. So something else that was mentioned a little bit ago was sort of the impact on other medications or on conditions as well. So the question we have here is generally, and it's quite a general question, is what impact does keto have on medication? So for example, there is one example here where someone has written in that their psychiatrist doesn't want them to do the keto diet. Apparently the psychiatrist is advising to stay away from any extreme diets, in quotes, and has some concerns about how medications are metabolized when following a keto diet. So does the keto diet affect medication metabolism?
Do you want to take this at a broad brushstrokes level?
Yeah, absolutely.
You know, first off, anyone's very individual, which is the beauty of being a doctor. Actually, is looking after the individual person's care and then telling you when you're doing things right or wrong. So the individual case for someone will be different, because the inclusion criteria for most of the studies is someone's been euthymic for about 3 months or so, and probably not having a mixed state and other things like that, and no recent changes in medicine. So it's a different sort of criteria when someone comes in. So there'll be a lot of caveats, and obviously can't give individual advice, but generically, you would ask yourself, well, what's the ketogenic diet doing to your body? Is it going to affect your liver metabolism and different aspects of metabolism when we're metabolizing medicines, isn't it? Lithium, well, ketogenic diet's going to affect electrolytes, so you're going to probably need to make sure that you're not getting dehydrated, because some people might get a little bit dehydrated with any type of diet or any change, and you'll need to be on top of that. But people are aware of the signs with regard to lithium, and if they're getting any signs of lithium, either toxicity or otherwise, but you'd want to have that monitored at least. So theoretically, there could be an effect on lithium. Now, with the other medicines, I don't like the term antipsychotic because it doesn't really tell you what the medicines are doing. We'll use that terminology. I would say, I guess, olanzapine increases all those cardiometabolic factors. And so that might actually stop a ketogenic diet working so well, which would be a concern for that. But does the ketogenic diet affect metabolism of the medicines? I'm not aware of any clear reasons why it should be affecting the liver enzymes that we have that metabolize the medicines, like CYP2D6 and the rest of them. But sensible thing to do, I would say, would be monitoring levels if at all possible, and just being aware of that. You're doing the trial, Iain, so you guys will have specific criteria, I'd have thought. Have I covered most of the stuff from a broad psychopharmacology point of view?
Yes, so in the kind of trials at the moment, people remain on medication as usual. So the ketogenic diet is added on to their existing medication. This is what we did in the pilot study. And one of the interesting things is that we saw people losing weight and losing their blood pressure whilst on medications that typically can make these things quite difficult. Like you say, olanzapine. We had a patient on olanzapine who lost 22 pounds over the 8-week trial. And so to see that it's possible to improve some metabolic health parameters whilst taking these medications is encouraging, because maybe you can add this on with the medications and kind of maybe prevent some of this weight gain that so many of us experience and have struggled with. This would really be great for young people in particular when you're in high school and you put on 30 or 40 pounds taking these medications. If this was a way you could add on a therapy to kind of mitigate that, that would be very interesting. So yeah, at the moment, this has been used in pilot studies as a adjunct to medication, and we need to do research to understand what the interactions might be. But definitely.
And I think sorry, I interrupted you there, but I think you raise an important point about as an adjunct. And I'd be very clear, people should not be stopping medicines to go on a ketogenic diet or for doing anything else without discussing with the person responsible for giving them the medicines and their family or members and other folk. And people know this, people with bipolar know this, but it's important to underline it. People should not be stopping medicines if they're starting the ketogenic diet or not, because there has been some stuff online where people have said, well, I've stopped this. And, it just creates more problems as well. But people are generally sensible.
Yeah, and just to remind everyone and the audience that we're not offering any medical advice here, because we don't know what your specific situation is, so therefore we can't give you any advice. So if you do have concerns and questions related to your own care, definitely talk to your GP and or psychiatrist first before making any sort of decision to start any diet. But I thought it was really interesting how you mentioned sort of like it's the ketos, not sure about the ketos effect on the liver enzymes, for example. So I think maybe what's kind of getting lost in translation is that it's not necessarily the keto on the medications, but it's the other medications on the keto. So, as you said, being on some antipsychotics could make, this sort of process faster, therefore maybe it's not going to be working. And similarly, if you're on lithium, which you've already mentioned, with the electrolyte imbalance, it's going to cause some more concerns and more harm potentially. So it seems very important, at least if you want to start any sort of diet, including the keto, to think about what medications you're on and discuss that with the relevant people. Seems to be the wisest thing. I'm noticing we have 5 minutes left, so I'm going to go to the next part now, which is kind of about other conditions, which I think is really interesting here. So there were several questions that came up regarding how the keto diet could interfere with sort of comorbid conditions such as epilepsy, as you already mentioned, diabetes, but also things like restrictive eating disorders such as anorexia. Where do we stand in relation to the evidence base of metabolomics, keto, and these conditions?
So this is really a question for Samir as a psychiatrist. I'm a researcher and I can't offer kind of medical advice on this.
Yeah.
But I can mention that there's multiple conditions. Ketosis has been used for obesity, type 2 diabetes, and epilepsy, where it can have beneficial effects. But for people with eating disorders, the research indicates that this should not be recommended to people with eating disorders, and people should be very careful. And so in studies, we've excluded people, unfortunately, with eating disorders from being able to participate because it's not the right approach for them necessarily. So I'll pass this to Samir.
No, I fully concur with my Scottish colleague, because if you think about eating disorders per se, when we look at the literature and what's happening to your brain and energy, metabolomics, it's obviously going the other way, and you'd just be accentuating any ill effects on the brain for people. And I think the main message is people need a period of I would have thought people would need a period of stability with their eating disorder. So of course you're not going to prejudice someone saying because they've got an eating disorder, but predicated on their health, if they're still in the throes of that, of course you can't offer this. You couldn't offer a diabetes medicine or GLP-1 drug, Mounjaro or whatever else, someone with an eating disorder because of the ill effects. So you couldn't do the same here. And again, you obviously discuss it with people, discuss it with your doctor, but no, it is difficult for folk, and you just need a period of stability. And people do get stability with most of our psychiatric things. So we need to be optimistic about these things, and that people are offered things without prejudice.
Yeah, I mean, I agree. I think, though, there's also sort of a question over maybe thinking about one's own motivation for using or engaging with the keto diet. Because from my understanding from friends and family, people have wanted to try the keto diet purely for weight loss, for example. Whereas if you're wanting to engage with it from a sort of bipolar symptom point of view, rather than any sort of weight loss or weight gain, I think that could be a healthier way to kind of maybe think about what sort of treatments you want to engage with and try. But it's something that's come up quite a few times, discussing with Tanya at Bipolar UK, kind of what our stance is generally, like professionally and personally, around diets and their inclusion within treatments. And it's something I know I feel sometimes uncomfortable with because of maybe my own history with sort of eating related issues, but also just generally it's evidence-based too. But I think we've had a really great conversation on that. I'm noticing we're now about a minute off the end, but I wanted to ask just a final question, hopefully, if we can be quick, around sort of like the potential overconsumption of things like protein and underconsumption of maybe fiber, and also managing cravings for carbohydrates. Do you have any sort of thinking about this and what it might mean and lead to for people?
The great thing about this is it can be done as a vegan or vegetarian. Many people use a vegan or vegetarian keto diet with high fiber content, and you can really eat lots of leafy greens, and many low carb. Most kind of vegetables are low carb by nature, and so you can eat quite a lot of vegetables as part of the diet and maintain fiber intake. And it's naturally a moderate protein diet. Actually, by definition, when this was developed for epilepsy, the protein was moderated because it turns into glucose. About half of protein turns into glucose. So you actually eat only 15 to 20% of calories as protein on a ketogenic diet. So there's many ways of adapting this to be sustainable for people. And as we're coming to close, I just wanted to point out that, again, one of the best ways to interact with this is through research. This is a safe way to interact with this kind of, there's no shortage of opportunities to try this along different lines of vegan or vegetarian versions through research. And this is done in a way with psychiatrist supervision, with lots of support and help, where we can explore these new treatments. And I think exploring new treatments is only a good thing for people with bipolar. We really need new and more effective treatments for patients. And so this is a great way to engage with this would be through research.
Yes. Thank you so much. And I think that's all we have time for this evening. So thank you to Dr. Campbell and Dr. Jauhar for this illuminating conversation. Remember, everyone, please join our research community to get updates and invitations on research just like this, and carry on the conversation over on the e-community with the live Q&A with Professor Daniel Smith on the 22nd of April at 1 p.m. to 2 p.m. Thank you.
Thanks, Talen. Have a good evening, folks.
You
Thanks.
too. Bye.
Bye-bye.
Thank you. Excuse me. Thank you to the team there. Thank you, Dr. Samir. Goodbye.
Goodbye. Have a good evening, Leah. Thank you very much.